positioning maneuver or the CRM. Can I have a student volunteer? Thank you. Here. All right, have you sit right there on the crack, facing away from me. All right, so I'm going to treat right side just so she turns towards you guys and you guys can see a little bit better. So the first part of the Epley maneuver, the CRM, is the positive Dix Hall pipe position. So some of you are already probably thinking, like, if I do the Dix Hall pipe and they test positive, can I just be into my maneuver already? Yes, you can. Yes, you can. So if you're that quick at thinking and thinking of what is the diagnosis, what does this mean, what's the thing to treat it, oh, I'm already there, then yeah, that's what most vestibular therapists do. So, all right. So say I'm doing my Dix Hall pipe test, so I'll have you turn your head to the right, and on the count of 3, we'll lay back. Please keep your eyes open. If it's a positive test, you'll have some dizziness here. So 1, 2, 3. Very good. So we're here. Nystagmus is upbeating, posterior, torsional, last 3 seconds. I'm adding, I could wait for a minute, or I could just add 30 seconds after it stops. Both are fine, but I do want to wait extra before I move to the next position, so position 2. So I waited 30 seconds after the nystagmus stops. All right, so now without lifting your chin up, I'm going to have you turn your head from right to left. 1, 2, 3. Very good. So you can see on the picture there what the crystals are now doing when you go from B to C in the picture. Now they're moving more. The reason that we have long time holds, like 30 seconds, 1 minute, is because our endolymphatic fluid in our ears is thick. It's like syrup. So it's just like little rocks floating through syrup. That's why it's a minute on all this. It takes some time there. All right, so in this position 2, I'm waiting 1 minute. So say 1 minute has gone by, I'll have you go ahead and bend up your right knee. So you're putting your foot flat, yep. And now I'm gonna have you roll onto your left side with your head down towards the ground. Like this, like all the way.
Should I have not?
Turn. There you go. There you go. Maybe not hanging off the table that way, but yeah, you're tucking your chin into your shoulder like that. So the patient's now lying on their side, their nose is down towards the ground, and yeah, I just have bend their right knee just to make it a little easier. So you're here for another minute. A lot of therapists will, there's no research on this, it's just what therapists say, and I have experienced this to be true. If it's working, what you're doing is working, a lot of times they'll get really dizzy in this position. So.
Should my head be on this or no?
No, like down. So this is where you go from extension, cervical extension, to flexion. So your chin's tucked into the shoulder is a good way to cue that. So I'm waiting here 1 minute, and then on the count of 3, I'm gonna have you push with this hand, push to sitting, and keep your head turned on the way up. So go ahead and kick your legs off and push up. Like off this way.
Oh.
There you go.
I could have done that smoother.
And then hand stays on the patient. It's part of the safety for the practical, and you're lowering the table down so that their feet can be on the ground, and you're kind of just with them until they feel stable and they don't feel like they're dizzy. A very common thing for sitting up from this position is something called a kickback phenomenon, and that's when the crystals just drop like clunk back into the utricle, and the patient just gets like a huge wave, and they'll usually like throw themselves back. So if there's like a wall here or something, or just off the table. So I have some people, they'll just they see a ghost and they'll grab you, So you definitely don't want to just sit them up and then, just not be next to them. So I always keep my hand on the patient until I'm talking to them and they're saying, oh, I'm good, I'm okay, thank you. So, yes?
Are they looking straight down or down to the last side they were on when they were coming, before they come up?
Straight down. So chin into shoulder, nose absolutely down towards the ground.
So they still are positioned.
Yeah, so that's when you go from extension, extension, to flexion, nose down towards the ground. And that's when that D letter there, that's when that, you see it's just like a free fall from the semicircular canal back down into the middle, into that utricle. So you're putting it back, and then for it to stay there, you're sitting up with their head still turned. Once they're up, you're done. There's no wait a minute here or anything like that. You're just kind of just talking to the patient, seeing how they're doing. So, how do I know if my maneuver worked?
No dizziness.
That's not sure.
How did I find out that they had a problem?
Ask them.
Retest
Oh,
them.
bikes.
Retest it, big salt bike test. So I'm waiting 3 minutes. This is kind of the preferred time frame. It's varies between therapists. The only study I'm aware of is done in Japan on the vestibular anatomy of frogs. So they don't really know how long to wait. They just know don't do it right away. And that was like 4 minutes for frogs. So most of us wait 3 minutes, 2 or 3 minutes between just kind of relaxing, resting. I'm educating the patient the whole time. This is what you had, this is what we did. In a minute, we're gonna recheck. And if it's still there, then we'll do another maneuver. If that's okay with you, if it's gone, then we're done for the day. So it's about 1 to 3 sessions is kind of the average for fixing just straightforward BPPV in one canal. It's more complicated. Let's see.
Is it different maneuvers for different canals, or is it just the same? Like if you're doing anterior, is it the same maneuver?
For the purpose of this class, yes.
But in real life?
In real life, this is the preferred maneuver. This is a gold standard. Sometimes you're seeing patients 3, 4, 5 times and it's not working. And there are many other maneuvers.
But I'm saying, if it's, for this one, you said she had posterior upbeating, blah, 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 blah. If it was anterior for downbeating, is this the same maneuver to cure that, is what I'm asking?
For the purposes of this class, yes.
No, but I'm saying, as a clinician, is it, or is it?
No, I'm doing
different?
a deep head hang maneuver.
It's different, oh,
Yeah,
okay, okay.
yeah. Which is like exactly what it sounds like. You just like go straight back and you just have a patient hang out there for like 3 minutes with their head hanging straight back. And that's like a little bit preferred amongst vestibular like experts to treat anterior canal. But yeah, there's so many. There's one that came out this week that I saw. It's called the sleep maneuver, and it's like you lay down straight and you wait like 3 minutes, and then you just turn the other side and you just go to sleep. So like that's like an easy one to like give somebody for like to do at home, because they're probably doing a pretty close version of that before they go to sleep anyways. So yeah, there's every month new maneuvers come up. So it'd be way too much to put that in this class, so we stick to the basics for this one. You guys want to practice just that, or should I